Hello everyone, welcome to another series in the Academy of Online Radiology Education. My name is Ricky Olmstead. I'm a radiology resident at the Baylor College of Medicine in Houston, Texas. This month we have curated some interesting literature in abdominal radiology. I was helped out by Dr. Alice Fung, a body imager at Oregon Health and Science University. First, we'll review an article from the Journal of Abdominal Radiology titled IgG-Related Disease in the Abdomen and Pelvis, Atypical Findings, Pitfalls, and Mimics. This article discusses the different findings of IgG4-related disease, which is a condition that can have a broad range of effects. The more common effects include pancreatitis, cholangitis, renal disease, and retroperitoneal fibrosis. Less frequently, it may involve the liver, appendix, and prostate. Treatment of IgG4-related disease includes glucocorticoids and immunosuppressants. However, even with treatment, about a quarter of patients relapse. Next, another article from the Journal of Abdominal Radiology. These authors review abdominal emergencies in patients with an underlying malignancy. In this patient population, acute abdominal pain may be related to their cancer, may be secondary to therapy, or their pain may also be due to any of the standard pathologies that affect otherwise healthy patients. It is important to keep in mind that an acute abdomen may be the first symptom of the patient's cancer. An example of this, not too long ago I had a case where a patient came in with abdominal pain, a KUB demonstrated pneumoperitoneum, and CT demonstrated a necrotic transverse colon mass that had perforated the bowel. The patient had no previous diagnosis of cancer. Some of the more common complaints in patients with the malignancy include bowel problems like obstruction, perforation, or ischemia. The article reviews these findings as well as hepatobiliary, GU, and vascular causes of acute abdominal pain. The next article is a multi-institutional review paper from France published in AJR and looks at CT and the management of acute mesenteric ischemia. The article discusses some of the imaging findings in mesenteric ischemia, including changes in bowel wall caliber, attenuation differences, and dilated loops of bowel. CT helps stratify acute mesenteric ischemia as early or late, which depends on if the damage is reversible or not. Necrosis is the big imaging finding associated with acute ischemia. Other clinical symptoms include signs of organ failure or an elevated lactate. Urgent treatment is important in these patients, as mortality is nearly 100% if left untreated for more than 48 hours. Treatment options include endovascular and surgical techniques. CT plays a role in demonstrating if a patient just needs revascularization or if the bowel cannot be saved if bowel resection is indicated. Next is an article by a group from Nara Medical University in Japan, published in the Japanese Journal of Radiology, and looks at how well MRI can predict dentate line invasion in low rectal cancer. In patients with rectal cancer, it's important to note if the tumor involves the dentate line, as treatment varies. If there's no involvement of the dentate, the patient can possibly undergo sphincter-preserving surgery, but if the dentate line is involved, a more extensive surgical procedure is usually required. Two radiologists correctly predicted dentate line invasion in 94 and 91% of patients respectively when compared to post-surgical histologic analysis. This demonstrates that MRI is fairly accurate in predicting dentate line involvement. The two radiologists underestimated the distance from the tumor edge to the dentate line by 5 millimeters when comparing the MRI to surgical pathology. This discrepancy is possibly due to inflammation around the tumor or difficulty in interpreting the transition zone. Next, this radiographics review by a team from Virginia Commonwealth University gives an overview of benign and malignant small bowel neoplasms. The article begins by giving the epidemiology of small bowel neoplasms, including that small bowel cancer makes up only about 0.5% of all United States cancers. However, the incidence of small bowel cancer is increasing. This may be attributed to the fact that most small bowel malignancies can be asymptomatic for a long time, and the patient may have a CT done for another indication and the tumor is found at that time. The article discusses different imaging modalities used in imaging the small bowel, including old-fashioned small bowel follow-throughs up to the newer MR enterographies. The authors give example of some of the more common small bowel tuners, and it's important to note that GISTs can be either benign or malignant. This next review article from AJR looks at the new AJCC T&M classification for abdominal cancers. More specifically, it looks at the N part of the acronym, the lymph nodes. The article discusses different lymph node drainage pathways for malignancy of the digestive tract, including the esophagus, as well as cancers of the different abdominal organs. It's important to be able to identify which lymph nodes are involved and if the nodes are considered regional or distant, as this affects management. This next article out of China was published in the European Journal of Radiology and looks at the concept of radiomics, which attempts to extract quantitative data from images and use that data to predict cellular features of the tissue. This was a retrospective study which looked at approximately 770 patients with gastric cancer who underwent radical gastrectomy, and found that by using radiomic data, such as localizing the tumor to a part of the stomach with demographic information and available lab results, all this data was able to better predict nodal metastasis than just CT alone when compared with surgical pathology. This next retrospective study from Tehran University of Medical Sciences in Iran was published in the Journal of Abdominal Radiology and looks at how well CT can predict the presence of and bleeding risk of esophageal varices when compared to EGD. CT did just okay in identifying high-risk varices, with a sensitivity of 63%. There was a positive correlation of coronary, gastric, and paraesophageal collaterals with varices. However, this was not the case with some other findings of portal hypertension. There was no correlation with splenomegaly, paraumbilical collaterals, and IVC diameter. This next retrospective study, published in AJR, was by authors from University Medical Center in Hamburg, Germany, and analyzed the diagnosis of diverticulitis. The authors found that out of about 560 patients with proven diverticulitis, CT was close to 100% sensitive and specific in detecting acute colonic diverticulitis. These 561 patients were part of a group of over 1,000 patients who had a CT ordered to evaluate specifically for diverticulitis, so a little more than 50% actually had diverticulitis. The most common alternate diagnoses were appendicitis, which was then followed by infectious colitis, urolithiasis, and pyelonephritis. Finally, we'll discuss a radiographics article which presents an algorithmic approach to diagnosing abdominal wall masses. First in the algorithm, make sure the mass is actually a mass and not just a mass-like lesion such as a hernia. Next, determine the number of masses, as the differential changes for solitary versus multiple masses. Third, characterize the mass as fat-containing, fluid-containing, or solid. After these steps, clinical history can significantly narrow the differential. The article gives common examples of the most frequent lesions of each composition. For more details, you can read our blog, where you can find links to the original publications. Feel free to share your thoughts and questions on our forum. I'll see you next month.